Today's CAP webinar is on building the behavioral health or understanding the behavioral health system of care and navigating it to help find resources for our patients. Our speakers today are Shelly Nakaishi and Marielle Ramsay. Shelly Nakaishi is an assistant professor of family healthcare nursing in the UCSF School of Nursing, and she's also a consultant for our CAP portal. She is a certified pediatric nurse practitioner working as a pediatric primary care mental health specialist at UCSF Benioff Children's Hospital, Oakland, and she has over 15 years of clinical experience providing comprehensive outpatient psychiatric evaluation and treatment for children and youth. Marielle Ramsay is a licensed clinical social worker with extensive experience in providing therapy and other services for both Medi-Cal and commercially insured families with children and youth ages 0 to 18. She is an early childhood mental health specialist and has provided comprehensive services to the monolingual Spanish-speaking community. And currently, she is serving as CAP's care coordinator. So I will have a lot to share with us today. Just as a note, our webinar is being recorded for posting later. We will be saving the last 10 minutes of today's talk for question and answer. So please, as questions come up, please type them into the Q&A portion so that I can pitch these to our speakers at the end of our hour. Thank you so much, and I'll hand this over now to Shelly and Marielle.
Thanks, Joanne. We don't have any disclosures. CAP is funded by federal and state funding. Okay, so it's taken me, I've been working in psychiatry for 15 years, and it's taken me 15 years to figure this out. And I'm still figuring it out. So I really want to start with that. And I work in Alameda County in psychiatry for Children's Hospital, Oakland. So my lens is around Alameda County, and I just want to start with that. For examples, we use a lot in Alameda County. And I'm very open to learning more. I want this to be like a learning collaborative to learn more about your system of care and behavioral health as well, so that we can continue to build upon this slide deck and make it as inclusive as possible. And I don't know if you saw that first slide, but it is many roadmaps, and it's very confusing system. So even putting together this presentation, I think I needed therapy, to understand it all. Marielle, did you want to say anything else as well? Okay, so we have a lot to cover. I was wondering also if people in the chat could put what county they work in, just so we have a reference to, that would be helpful. Okay, so we're going to start off with a 15-year-old girl with increasing depression that you're seeing in primary care. Where do you refer them to therapy? And I know that we like algorithms, so we'll get to one, but the next step is, next slide, Jessica, is like, how do we figure out, how do we figure this out? But the first step in the referral process is actually obtaining consent from the family and the youth themselves, and really encouraging family involvement. In our referral process, sometimes we'd get a referral from a primary care provider, and they say, this patient wants therapy. And then we call them, and they're like, no, we don't. Who said this? And so really getting consent is really, really important, and getting their buy-in into the next level of care that they're seeking. Okay, next slide. So I tried to map this out. After you get consent, where do you refer them to? Well, it's based on their insurance, whether or not their school has services, whether or not they're a client of regional center. And then based on insurance, you break it down by severity level, diagnoses and age level, and if there's any system involvement. So that's kind of the high level picture that we're going to walk through these slides. Okay, next slide. So just as a quick overview for behavioral health, it's carved out separately from medical health, but there is parity that everyone must receive mental health services as well. In commercial insurance, you call the back of the phone number and ask, where do I send this young patient for therapy? You can look online, and there's services like Psychology Today to find providers in your area that take certain insurances, or you pay out of pocket. And then for public insurance, the middle section, the purple section here, you can call. Every county has a behavioral health county access line that you can call and ask, hey, I have a young person, I want to refer them to therapy. Where can they go? And so either you as a provider can call, the family can call themselves, the youth can call themselves to seek out services. If it's something urgent, I like to do it together with the family in the visit, if possible. It seems to go quicker as far as getting the referral through. And then if there's no insurance, the counties and state usually provide some mental health services for no insurance situations. A lot of times the primary care FQHCs can as well. And if there was a crime that happened, victims of crime funding can often provide therapy and mental health services, as well as there's a lot of grant programs out there. So different programs can provide those services. So that's the high level overview by insurance. And the next slide.
Yeah, so a lot of mental health services are funded and provided in schools. So it's finding out what or supporting families and finding out what mental health services are provided in the school can be helpful. It is, some schools have their own counselors, school-based counselors, where an IEP is not required or wellness center is not where they can go. But some services may require an IEP, which they can get with a mental health diagnosis if it's impacting their functioning at school. And through that, there's like a whole spectrum going from, school-based therapy all the way to being in a specialized classroom where there's a therapist in the classroom, all the way to a non-public school, specialized school. And in some very rare cases, there's also residential placement through the school. But as mentioned, a lot of specialty mental health, Medi-Cal funded programs are based in schools. And so it's a good place for families to first inquire about therapy. Next slide.
Okay, so now for therapy, it's through the insurance or seeing if the schools can provide therapy services. Next slide. And then there's increasing severity levels. So where do you refer to now? Next slide. Next slide. So, okay, understanding public insurance, and you all may understand this more than I do. For public insurance, Medi-Cal has broken it out by fee-for-service versus managed care plans. And it's kind of like fee-for-service is PPO and managed care plans are like HMOs. So at the managed care plan levels, I'll just include that to include fee-for-service as well. That's where you can receive mild to moderate mental health services. So the managed care plans that contract with a service that provides mental health services for mild to moderate kind of severity. And if you can hit the down button or to animate it, Jessica. Okay, perfect. So then if it's more moderate to severe levels, then it's carved out under specialty mental health services. It also carves out for substance use treatment. So based on severity level, for public insurance, you can go to the managed care plans or into specialty mental health services. Okay, next slide. So this is just looking at it at a different level, and if you can animate here, Jessica, that basically there's this new a new initiative which is called CalAIM, and it's already started to help out in providing some changes into the mental health services. It's going to be for medical and mental health. I'm only going to speak to a little part of the mental health piece that's been happening. So before CalAIM, before this initiative started, basically, if you wanted to receive specialty mental health services to see a certain psychiatrist or a certain place for therapy, you had to meet a requirement. You had to have a certain diagnosis. You had to have a certain number of symptoms to come into specialty mental health. Now with CalAIM, since July, no specific diagnosis is needed. And so it's no wrong door. So you can come in and we can say in specialty, oh, this is more mild to moderate. You should kind of go back to, your managed care plan and then set up services there. But we will still do the evaluation in the specialty, or we would do the evaluation in the non-specialty and refer you up to more specialty. Also, if there are certain diagnoses or conditions like trauma, a history of trauma, or system care, foster care, or juvenile justice, you automatically can qualify for specialty mental health services. The other one thing that we've been fighting for and has been changed is it's reduced the amount of documentation that we need to do in specialty mental health. So that's been wonderful for me and all the other mental health providers, which hopefully increases access to care because there's less burdensome of documentation. So next slide, please. So each county behavioral health system sets up their clinics unique to their county. Alameda County contracts a lot with community agencies. Alameda County contracts with Children's Hospital Oakland to provide specialty mental health services. They also have special county clinics as well. And some counties also, they contract and provide mental health services on site at schools as well that meet the specialty mental health levels of severity. Okay, next slide. This is just a kind of general overview that we look at as far as a continuum of care, where it includes the ideas of prevention, which happens in primary care, actually, where in a sense you're screening like for maternal depression, and knowing that might have an impact on the youth or the child's mental health as well. Then there's consultation services like CAP. You have a 6-year-old with possible ADHD. What should you do next? You can call the UCSF CAP to get consultation. And then now your higher level care, they go to outpatient care for therapy or for medications to see a psychiatrist. Increasing levels of like severity, a crisis happens, then more intensive treatment is needed in the red 5. Then a possible psychiatric hospitalization could happen. If it continues to be unstable, and a residential treatment may be necessary as step 7. And we don't want to leave out this idea that we should have recovery models of care as well. And we'll talk a little bit about that as well. Then the blue section up on the far right corner is really just talking, there are some special services for mental health that we'll kind of touch upon, most of them, but not all of them, where it's more specialized, like around substance use treatment. Okay, next slide. This is a document that you can find on the this linked website at the bottom, Child and Adolescent Psychiatry, ACAP website, but it walks through what are the different types of cares and gives a brief description of them. I believe you'll see this slide deck as a handout, so I'll just go through some of the main ones that may not be familiar. Like intensive case management is around care coordination. Sometimes there's home-based services that are specialized, like ABA, or applied behavioral analysis for autism, or therapeutic behavior supports, TBS, which go in the home. There's definitely family support services where you can call to get parent support. There's day treatment, pre-treatment programs where it's more intensive therapy, when they might provide some education services while you're there. Then there's partial hospitalization, which is again more intensive treatment. We'll talk a little bit more about that. There's crisis services, hospital treatment. Respite care is like in-home health support, or through the regional center, you might be able to get respite care for some youth. There's the levels keep going up as severity around therapeutic group homes, crisis residence, and residential treatment. Okay, next slide. So that's a quick overview, as quick as I can do. And then a continuum of care, looking at it, dividing it up versus commercial versus public. In commercials insurance, they have after crisis intervention severity, they have IOP, intensive outpatient, and partial hospitalization. But in public insurance, Medi-Cal, the level of that matches that would be our therapeutic behavior support, TBS, or intensive care coordination. Okay, so that's comparison of insurance. Next slide, please. And then this is just another slide to kind of break it up by IOP, intensive outpatient treatment, might be 2 to 3 hours that you're going in and doing visits and for 2 to 3 times a week, versus if it's more severe, we're trying to keep you out of a hospital, but it's called partial hospitalization. So you're just going there for the day and coming home at night. Next slide. And these are some of the local Bay Area IOPs, PHC that commercial insurance will provide. And hopefully in the future, we might see more of this in Medi-Cal, like Charlie Health is a virtual IOP, and they may be opening up services for Medi-Cal insurance as well. Next slide.
Yeah, so I just want to mention that we're also going to send a handout that has information about all of these different services and some examples of them. And so, as Shelly was saying, the IOP and PHP is when you have patients who need a higher level of care with commercial insurance. When you have Medi-Cal clients who are moderate to severe and are needing more intervention than maybe just a therapist, there's something that can be added on to the therapy called TBS, which is a short-term intensive service, often more like 3 to 6 months, where they have the provider coming into the home multiple times a week, and they're a licensed clinician. So this is really focused on when there's a risk in the home to their placement, or the family's really struggling to meet the child's needs and keep them safe, or they're at risk of hospitalization. So this referral, these are county programs. So this is something that a therapist has to refer to. But if you're concerned as a provider, like, okay, that therapy they have, but I'm seeing a higher level of need, TBS is a great service. Next slide. The other higher level of care that's provided by the county for Medi-Cal clients is intensive care coordination, or RAP services. This is a fantastic intervention, especially for our patients that have a big team of providers. Let's say they have a therapist, they have a social worker with the county, they have a TBS worker, they have school-based work, they have a big team. But it can also be for smaller teams, but it basically allows for a monthly meeting to coordinate the child's care and to support the caregiver in managing their services. So it's facilitated by often a clinician whose job is to facilitate these meetings and coordinate the team and work with the different partners on the team to make sure that their services are meeting what the current needs are. And again, the referral depends on the county, but it's usually through the county that the referral is made. Next slide.
Okay, so now we're having more increasing severity with active suicidal thoughts and plan. So next slide, we're gonna enact, there is some counties have mobile crisis. Some county regional centers also provide mobile crisis services. Those are often the first line to consider calling. Then there's either going to the emergency room or a crisis stabilization unit that we'll talk about next. And there is the new suicide and crisis lifeline statewide, actually federal wise. It's 988 to use now. And so they will, do everything they can to address safety. And if not, then the police would come and assess, or depending on the county system you have. Okay, next slide.
Shelly, I just wanted to add that, like a lot of counties, the access line is a crisis line as well. So 988 is more like the suicide hotline. And if it's a crisis where a parent really needs support in crisis, they can call the access line in many counties.
Oh, thank you, Marielle. Okay, so what is a crisis stabilization unit versus an emergency room, or CSU for short? Most counties do have CSUs. in Alameda County, we have this, it's run by STARS. It's at Willow Rock, and it's for ages 12 to 17-year-olds. Whereas in San Francisco, they have one for 6 to 17-year-olds, and Crestwood and Fairfield has for all ages. So it really depends on each CSU at what age levels they accept. And it's a more directed short-term psychiatric assessment. So you're not having a young person sit in an emergency room with, that might be open to all kinds of emergency situations. It's much more direct. The idea is that they will be seen there for up to 23 hours and 59 minutes to determine whether they can safety plan them home with services and aftercare, or whether or not they would have to go to a psychiatric hospital. Okay, next slide. Did you want to say anything more, Marielle or Petra, on that? Okay, so this is just a picture of the greater Bay Area's psychiatric hospitals for youth, most except Medi-Cal. And some have special requirements that they don't accept any patients with encopresis. And we all know it's very hard to have somebody psychiatrically hospitalized if they also have an intellectual delay, or they're on the spectrum and they're nonverbal, and they have mental health, crisis situations. We know how difficult that is for everyone. Okay, so, and we know how limited beds are, and this is a challenge statewide and countrywide, actually. So yeah, so if we can do more prevention and recovery, we need to look for these solutions. Okay, and changing some of this federal funding ideas too. Next slide, please. But I'll get off that mantra. We could go down a deep hole there. Okay, so now back to Marielle.
Okay, so let's say you have a patient who's really high risk, safety concerns, has had hospitalizations, and the services that they're receiving and the family's receiving is not sufficient, and the family wants to consider what's the next higher level of care. Next slide, please. So again, this is dependent on your insurance. If you have commercial insurance, there's a number of residential programs that are available. Again, we'll send this in the handout as well. Some of these are examples of some of the Bay Area ones. Some are more inclusive of the family. Some are also inclusive of a substance use disorder. So it often requires either the family, the pediatrician, case manager, someone exploring where are their openings and where would be the best fit for my child. Next slide, please. This is much harder access for Medi-Cal clients. They need to go often through one of the public systems, whether that be the school system. Again, that's more rare. The foster care system, which is increasingly rare as many counties are moving away from residential placements, through the probation system or through the regional center. But at that point, the client would probably be involved in those levels of care, and that might be something that's being considered. Next slide, please. There's so much to say about, these are some examples of regional center crisis stays in residential care. One thing that's important to note is that they're very limited, and these aren't emergency placements. Same with residential placements with commercially insured, but especially with regional center, it's like a planned process that involves the clinical team and the case manager. Next slide, please. So regional center is a way that people who are clients of the regional center and have a disability that qualifies them, which is often autism, cerebral palsy, epilepsy, or other conditions before their 18th birthday. Once they're a client of the regional center, there's a number of support services that are available that can really help with the mental health of the client and the family. Shelly mentioned respite care. There's often the case manager, family services, advocacy support. A lot of times, some regional centers have their own mobile crisis team or crisis program, like we talked about, and some will also support with providing ABA, or otherwise referring to their managed care plan to find ABA. And then, like we mentioned, there's a limited amount of cases where there's residential placement. And regional center is required to fund mental health services if the patient is denied by the county. So a lot of kids are denied by the county because of their disability. They'll say we can't serve that child with that level of autism. And so if the parent gets a denial letter from the county, they can go to regional center, and regional center case manager has to find mental health services, and regional center has to pay for it. Do you want to add anything, Shelly? Okay, next slide. So now let's say that you're concerned that this 15-year-old who was having depression is starting to look now to have more of psychotic symptoms. Next slide, please. And you might be considering, we want to then consider a program that specializes. So a number of counties have early psychosis programs. It's funded whether through Medi-Cal or through commercial insurance. So these are programs when there's concern for psychosis developing. And so for commercial insurance, there's specific psychosis programs, such as the ones we mentioned here. And then for public insurance, there's often county funded programs specific to that county. These are really like evidence-based, comprehensive programs, support the whole family, and can create a lot of hope when families are at their end for kind of how to help their child. So again, if it's commercial insurance, they'd have to go through finding commercially insured programs, and then public insurance they can access through the access line. Next slide, please. I just wanted to make sure that people know that these programs are trying to also support, I shouldn't say generally, some of them might have a requirement of a psychotic break already, but a lot of these are trying to prevent psychosis. So these are just some of the symptoms you might notice when you see someone you think is depressed, and then you start to notice some other kind of more unusual symptoms, like real sensory sensitivity, a lot of isolation, and some other things that might actually qualify them to be assessed as appropriate for a psychosis program. Next slide, please. Now, let's say you have a 15-year-old who is having either a substance use or eating disorder concern, and you want to try and find a program that specializes in those. Next slide, please. So it's important to note that with substance use disorder, like with a lot of mental health disorders, but family involvement in treatment improves the outcome of reducing the symptoms or recovering from the disorder. So finding support that's inclusive of the family is important. And a lot of substance use in adolescence can be addressed by mental health services. So you can go the route of finding a mental health therapist, or if they already have a mental health therapist, advocating for how are they addressing the substance use concerns within those services. But there are specific programs, again, based on insurance, but there are some county programs that are for both Medi-Cal and uninsured youth. For example, in Alameda County, we have Project Eden. In San Francisco County, there's a program called Horizons, and these have another funding source as well. So it's inclusive also of commercially insured. And then there's also some commercially insured specific programs for substance use, such as the one we have at UCSF, which then can help link to more treatment. Next slide, please. Eating disorder treatment, again, research shows that if family is involved in the therapy, and a lot of eating disorder treatment is family therapy based. So often helping the family find a family therapist can support their recovery. The public insured Medi-Cal can call access line and specifically mention the eating disorder or the managed care plan, and will be tracked to a more specific treatment for eating disorder. Same with commercial insurance, calling your insurance, requesting a case management support, and identifying an eating disorder specialist is helpful. There's also intensive outpatient, partial hospitalization, and residential treatment specific to eating disorder. Next slide, please. Another population we know you serve that is a unique population in services is transitional age youth. Of course, they can be served by adult programs, but there's also a number of TAY programs that they can access. So through specialty mental health programs, if they're already in a specialty mental health program, let's say through a community-based organization, once they turn 18, it doesn't mean they age out. Often they can stay somewhat longer than that. But if they're 18 and you're looking for specialty mental health services, there are specific specialty mental health programs for moderate to severe in the county, as well as specialized TAY shelters and crisis residential placements funded by Medi-Cal. And just important to be, again, as inclusive of the family and natural supports as a pediatrician in the referral process and treatment, because they're still really young and need natural supports. Next slide, please. And then again, if they autism is another specific need. A lot of times people, if you're looking for evaluation for autism, it again depends on your insurance. If you have Medi-Cal, then it's through your managed care plan often to get the autism evaluation. You call your managed care plan and then they will refer you. But you can always also go through regional center, though the wait time is very long. And the primary intervention for autism is ABA, but a lot of families with autism can benefit from specialty mental health services. However, it can require quite a bit of advocacy, as we mentioned, because they want to often screen out for autism and just refer to ABA. But a lot of kids with autism also have trauma or depression or anxiety or things that need mental health treatment. Next slide, please. And then lastly, let's say you have a toddler or a 1-year-old or with trauma or behavioral concerns. Where do you then refer those patients? Next slide, please. So this is really important. Like Shelly was mentioning, we want to we're trying to do prevention work, that kids are not getting caught up in the system and going to residential and all of that. And early intervention reduces the likelihood of entering the system or needing that later intervention. So really paying attention to babies and toddlers and what stressors they're experiencing and how are they developing, as 80% of brain development happens before age 3. So supporting families and accessing mental health services, I highly recommend referring families to Help Me Grow. We'll talk more about that, where there's a focus on the parent attunement. And there's a number of specialized treatments, both for commercially insured and Medi-Cal, that are specific to early childhood. Next slide, please.
Just want to bring in the concept of recovery programs and what that might mean. It's really, I just read a book by Thomas Insel about like recovery is about people, purpose, and place. So your community having a purpose and feeling connected for health and recovery. So ideas around this would be peer recovery networks, and there's quite a bit of them in California. There's a link that shows a lot of them that's provided here, as well as there's programs like Job Corps, which is part of residential placement where they can live, but it's not residential care, but they live there and they learn a trade and they're a school setting as well. And there's other programs, there's so many that couldn't list them all, but just ideas that it's around like youth job training and internships. It's about being in nature, it's dance programs, it's, you know, any youth programs where it's positive, healthy activities. We can think of those as recovery programs. Next slide, please. So we walk through this algorithm, hope to help try to make sense of how to make referrals. Next slide. And then this is just an idea of when we follow the money, we understand why maybe the system is set up in the way it's set up. So this is the public health funding sources. For state and local, they break it out into these buckets that are in the red circle: child welfare, juvenile justice, and so forth. And so if we go to the next slide, you see how these buckets kind of break down into what types of services are provided and why it was, you know, it's why it's a challenge to figure out how would I get this young person to residential care, what system or where does the funding come from. So that's kind of a way to trace things back and map it out in a way that can make sense based on what they made sense of it. All right, next slide. So what might that look like for a young person, is they could have all these tied to all these different types of services from different systems, like therapy from one community kind of setting and psychiatry from a different place, and they can also have a school therapist. And they can have all these services tied to this one young person. But now, if you go to the next slide, what if this family also has 5 children? That could be really hard for any family to deal with all these appointments, just for one child, now times 5. Next slide, please. And that feels very overwhelming. And so Marielle, take it away.
Yeah, and so Shelly and I, we understand our experience. The system is really focused on the problem is in the individual child, and it's very fragmented. What we know is many symptoms that child are experiencing are reflective of problems within the family system. And this is why we're encouraging thinking about the family and the family needs, and supporting the family to be included in that child's treatment. Next slide, please. Many of you may be familiar with Maslow's hierarchy of needs. So this really helps us understand. Sometimes a lot of therapy is focused on this self-actualization, esteem building, but these foundational pieces at the bottom need to be in place in order for a child to benefit from a higher level of therapy, like CBT or something. So are their physiological needs being met? Are they safe? Are they receiving love and care from their family? And so really also intervening on those levels. And we'll talk a little bit more about that. Next slide. So one of the ways to support families, because obviously as pediatricians, it's hard to assess what's going on and what they need and what sort of all these services, what do they need? So finding navigation services that have the opportunity to assess more and support them through the process. And there's a number of different doorways to do this. So we have, like we've talked about, calling the access line. Depending on the county, that's going to be a very different experience. Some counties have they do a thorough assessment. Some counties, their access line looks much more like we only do psychiatry referrals. So depending on the county, that's one place to start. Another place is the managed care plan. If they have Medi-Cal, like we've talked about, calling Alameda Alliance or Blue Cross Partnership Plan, and encouraging families especially to name what the major concerns are or risks are so that they are attended to, and that they can ask if they're having trouble finding a provider for case management support. Same with commercial insurance calling, they can ask for case management support. FRCs, some counties have family resource centers, which are often targeted towards families with children to support with meeting basic needs and linking them to basic needs resources. Verse 5, help me grow, I think almost every county has a help me grow phone line that is there to help family with children 0 to 5 and provide resource and referral. There's many counties have a program. We have a great one in Alameda County. That's a family resource navigator program. So these are for parents of children with disabilities. But yeah, so parent partners basically support them with either IEPs or accessing services, and they partner with them in this process. They might be less familiar with mental health services and more for developmental needs or other disabilities. Kinship programs are great. Many counties have those for family relatives who are caring for children. Parent stress lines are another place that parents can go. You can find out if you have one in your county. 211 is our county resource directory, has extensive information for basic needs. And then in terms of supports, this is when you're really seeing that there might be need for support groups or advocacy support. DREDF is in many counties. There's actually a couple other companies we didn't mention that are for some other counties in Northern California. Maxim, I think it's called, Maxis is another one, but DREDF is the main one for school advocacy help if they're not getting the services according to their IEP or their needs. There's also GALT, which is great for families who were denied SSI or IHSS. They will help with the appeal process. There's a number of legal aid agencies that provide free legal services. I'll send out that list in the handout. And then there's also online support groups, such as through NAMI. Next slide, please. And then lastly, we just develop these pearls of wisdom to support you in having a more family-focused approach in our individualized and fragmented behavioral healthcare system. So again, research shows that family involvement in treatment increases success, that really giving a little bit of space, empathizing with the caregiver, just like even for 15 seconds, can then support with problem solving. So empathizing with the stress and the feelings of the caregiver, making some clear goals when you're working with the caregiver and youth, like what the next step is, using that Maslow's hierarchy to decide where you're going to start in terms of helping the family, educating the family on like what we talked about today, so they're prepared a little bit for how the system works. And then as much as possible, following up, having a follow-up appointment, checking in with them, having the staff call them. We recommend calling 3 times. And then developing your own handout and familiarizing yourself with local resources, referring, as we said, to the navigation and advocacy organizations as a place to start, and focusing on the early intervention to prevent this higher level of need. Yeah, sort of some of our pearls that we wanted to share with you. Next slide.
All right, fantastic. Thank you so much for that great talk, and obviously a very complex topic on a very, very complex system. I think there are a lot of great pearls here.